A Type B malleolar fracture, AO classification 44B. A Type B malleolar fracture is caused by a pronation eversion mechanism. The trochlea of the talus is forced and rotated externally. The result is the fibula fractured in a spiroid fashion starting anteriorly at the level of the ankle joint. The distal fragment of the fibula is displaced proximally and slightly rotated. In about half the cases, the anterior syndesmotic ligament appears to be injured. However, the posterior ligament remains generally intact, but may avulse a posterior lip fragment of the tibia. On the medial side, the deltoid ligament may be torn or the medial malleolus fractured, showing typically a horizontal or transverse fracture plane due to the avulsion mechanism. A rather unstable and displaced Type B fracture is best stabilized with a 1/3 tubular plate. To function as a buttress or anti-glide plate, according to Weber, the plate must lie on the posterolateral aspect of the fibula. The straight skin incision is made along the posterior ridge of the fibula to prevent any interference with the superficial fibular nerve or the sural nerve. A 5-hole 1/3 tubular plate is chosen, where the oval hole may be used for axial compression. The instruments needed are the pointed reduction forceps and the toothed reduction forceps. Also required are the 2.5 and 3.5 millimeter drill bits, the 3.5 2.5 double drill guide, the depth gauge, the 3.5 millimeter tap with handle, and the small hexagonal screwdriver with holding sleeve. Usually, reduction is best obtained by placing the 5-hole plate without contouring onto the posterolateral aspect of the fibula. By applying the small toothed reduction forceps over the plate, the spike of the distal fragment is automatically reduced and held in its correct position. 2 plate holes should lie over the distal fragment and 2 over the proximal fragment. The middle hole may be used for an interfragmentary lag screw. The first 3.5 millimeter cortex screw is inserted through the plate hole just proximal to the fracture. With the 2.5 millimeter drill bit and corresponding drill sleeve, a hole is prepared through both cortices. The length is measured with the depth gauge. The thread is cut with the 3.5 millimeter tap. The appropriate length 3.5 millimeter cortex screw is inserted. By tightening the screw, the straight plate is pressed against the slightly curved bone. The result is a spring effect that increases stability. If the reduction is not perfect, the screw should be loosened and the distal fragment gently manipulated with the pointed reduction forceps. A 3.5 millimeter cortex screw is placed eccentrically in the most distal plate hole in the usual manner. To improve fixation, an interfragmentary lag screw is added through the middle hole of the plate. The 3.5 millimeter drill is used to create a glide hole in the near cortex. The 2.5 drill sleeve is inserted into the glide hole, and a 2.5 millimeter thread hole is drilled in the far cortex. The screw length is measured, and the thread is cut with the 3.5 millimeter tap in the far cortex only. The 3.5 millimeter lag screw is inserted, producing extra compression across the fracture. Finally, another screw is placed in the most proximal plate hole. With this kind of anti-glide plate fixation, the fracture is firmly locked and so stable that immediate weight bearing may begin. As an alternative, the same 5-hole 1/3 tubular plate can also be placed on the lateral aspect of the fibula, combined with an independent lag screw across the oblique fracture. Here, the postero-anterior direction for this screw is preferred instead of the anterior-posterior direction, which needs considerably more dissection to place the screw perpendicular to the fracture plane. The fracture is reduced with the reduction forceps that are placed so as not to interfere with the planned lag screw. The 3.5 millimeter drill bit and matching drill sleeve are used to prepare the glide hole slightly oblique to the fracture plane. The 2.5 drill sleeve is inserted into the glide hole, and the 2.5 millimeter thread hole is drilled. Measuring and tapping is done. The 3.5 millimeter lag screw is inserted to compress the fracture. The 1/3 tubular plate is prepared by flattening its profile with the parallel pliers to fit to the distal end of the fibula. The plate is also contoured to the distal fibula curvature. The parallel pliers and the wire bending pliers are used to twist the plate. While this kind of fixation provides excellent stability, it does not allow immediate weight bearing.